Hi, Adult Health 2. We are doing chapter 16 now, intraoperative. So we have rolled the person out of pre-op into the surgical suite, into theater, and we are getting ready to do a procedure on our person. Um, so slide 4, just a couple reminders of some vocabulary. Asepsis is the absence of bacteria, viruses, and other microorganisms. Medical asepsis just reduces the number of microorganisms present. This helps reduce risk of transmission, cross-contamination. This is why we use hand hygiene, gloves, gowns, disinfect our surfaces. And then we have surgical asepsis, which means no organisms present. Okay. Medical asepsis, we are just trying to keep our microorganisms to a minimum, not introduce anything new. Surgical asepsis is these are our surgery settings. You know, these days we don't just do surgeries in hospitals, right? So we may, which is inpatient. So that means the patient is admitted to the hospital. They usually require close monitoring for greater than 24 hours status post procedure. So they're going to be there admitted, have a room. But we also, and most commonly, have ambulatory or outpatient surgeries. These are same-day surgeries, right? Patient is admitted 2 hours before. They're usually DC'd directly home. They do not need additional recovery care beyond anesthesia. So once they are recovered in PACU, you know, they're free to go. They should be okay. So depending on what type of surgery, what location, that is going to determine who our surgical team members are. Okay, like how many, how complicated the surgery is. You know, you see these pictures of transplant surgeries, right? And there's a billion people in there. But that of course is not needed for all types of surgeries. So varying surgical team members dependent on the surgery itself. And then those team members may be sterile or non-sterile, okay? This is a surgical suite layout, just kind of a picture so you can kind of get an idea. The unrestricted zone, that's just street clothes, okay? Normal old street clothes. Semi-restricted requires surgical scrubs, head coverings, mask, no jewelry, fake nails, eyelashes, that sort of thing. And like when we are talking OR, it is important to note that, like, for the most part, you know, all facilities are like whatever floor you're on, no jewelry, no fake nails, no fake eyelashes. You know, we say that and nobody follows it. In OR, you follow it. That's a real life thing. So they actually mean it when we're talking the OR. So in the semi-restricted zone, you are limited to authorized personnel only. This area, semi-restricted, can include corridors, supply rooms, scrub sinks, and the anesthesia work area. And then our restricted area is actually where the procedure is performed. This is the most controlled space related to asepsis. We are protecting our sterile field, okay? That area is going to have positive pressure. If you remember, positive pressure keeps organisms out. Keeps organisms out. You have to wear appropriate attire, including facial coverings, footwear, masks that fully cover mouth and nose. Okay, so that's the restricted area. Restricted zone is just remember that's where you are sterile, period. So our sterile team members are those who work within the sterile field and have the responsibility of maintaining asepsis. So controlling the sterile field to avoid contamination by microorganisms. Um, and this is throughout the surgical procedure. The sterile field includes the OR table, and the area closely surrounding it. There's an equipment stand called the Mayo stand that is positioned close to the patient, and there's also an instrument table. The team members scrub their hands and arms with special disinfecting soaps and wear surgical gowns, caps, eyewear, gloves, and sturdy footwear with shoe covers. Sterile team members include the surgeon, surgical assist, scrub nurse, or surgical tech, or OR tech. Surgeon is considered the leader of the surgical team and has the ultimate responsibility for performing the surgery in an effective and safe manner. Depending on the complexity of the surgical procedure, the surgeon may have one or more providing assistants. Surgical assistants are practitioners with specialized training that allows them to assist with surgical procedures. Nurses can be first assist, okay? Career goals there for you. So these people can be PAs, surgical first assistants, NPs, and RN first assistants. So if you're an RNFA, so RN first assist or an NP, obviously you've done some additional education related to that role. Um, let's see. There's also going to be the scrub nurse, surgical tech, or OR tech. This individual works directly with the surgeon within the sterile field. They pass instruments, sponges, other items like that. Before an operation, the scrub nurse helps prepare the OR by setting up the instruments, equipment, the drapes, the solutions. They assemble both sterile and non-sterile equipment, checking to ensure that it is working properly. The scrub nurse is also responsible for helping the surgical team don sterile gowns and gloves in preparation for the procedure. So, like, I'm sure you've seen probably Grey's Anatomy, I'm sure, where somebody's helping the surgeon, like, get dressed, right? That would be your scrub nurse or scrub tech. The scrub nurse also, if there's specimens to be taken to the lab, anything like that, the scrub nurse is who's going to be responsible for that. So non-sterile people, your anesthesiologist is not sterile, okay? This too is a role as a nurse, obviously with special schooling, CRNA, that you can end up with. Not a bad gig to have for sure. Um, there's going to be a circulating nurse. There's going to be various assistive personnel, just again, depending on the size of the surgery and the needs. And also your OR director or manager may pop in to see how things are going, make sure that everything is going as planned, the surgeon has what they need, that sterility is being maintained, just kind of checking up on things. Priority assessments and procedures. So again, we start with that pre-op assessment that we talked about related to chapter 15, right? It all comes back to that pre-op assessment. Then they're going to do that surgical pause or timeout. This is also when they do a fire risk assessment. Okay, so that's kind of an added part to this timeout. Um, your sterile people are gonna do a surgical scrub. They're gonna don the surgical attire. Surgical count is going to be done. This is when you literally identify every single thing that is being used related to this patient. All the gauze, every single piece of gauze, every single piece of equipment, whatever you may have. It's counted, it's written down, and then when you are closing with your patient, you make sure you have accounted for, let's say we have 5 2x2s. 5 2x2s are accounted for. We're doing this so that we don't leave anything in the patient because that can happen. And then obviously when you leave a foreign body in a body, a lot of times the body wants to reject that. You can end up with abscesses, stuff like that, infection, ultimately leading to sepsis. So that's why we do a surgical count. Okay. Um, let's see. We're going to talk about implants. Remember, we talked about all of that. Implants, prosthetics, pacemakers, anything like that. This talks about the universal timeout protocol developed by Joint Commission. Remember, this is our second timeout. We did our first timeout in pre-op. All right. We kind of repeat ourselves a lot with this. Just remember that the priorities of the OR nurse with the pre-op assessments, there are 4 goals. We wanted to determine the patient's level of knowledge, confirm that informed consent was obtained, determine patient's level of anxiety, and we want to support and help them through that, and then obtain relevant information about the patient. And that's all review from chapter 15. This talks about the fire prevention. That is part of this intra-op timeout. Fire prevention in the peri-operative setting is a high priority. If all 3 components of the fire triad, ignition source, fuel, and oxygen, are present, the risk for potential fire is significant. The perioperative team needs to prepare the OR patient and sterile field with great care to prevent any harm to staff or the patient. Standardized interventions to prevent fires in the OR include communication of results of fire risk assessment during the surgical pause timeout, assessment of flammability of all materials used in and around the patient, notification to the surgeon of increased use of oxygen, checking all electrical equipment before use, confirmation of availability of sterile water/saline to extinguish potential fire, protection of all heat sources when not in use. The National Fire Prevention Association recommends fire drills and fire extinguisher training to be held to keep staff up to date on current safety fire practices. So just remember that they do this because there are a lot of flammable things in the OR. Or I should say there's a lot of components in the OR that when combined could be quite flammable. This includes oxygen, maybe cauterization. You do have electrical, you do have things that could cause a spark, right? You have sources. So fire's a real potential in the OR. So this slide just talks about the surgical scrub. This talks about making sure that your nails are short and clean. If you do have nail polish on, no chips in your nail polish. The book does specify, of course, no fake nails. Remove all jewelry. Wash hands thoroughly. You're going to use a disposable sponge to move from the hands to the arms. And the surgical scrub takes about 3 to 5 minutes in total. This is just a pic of somebody getting their sterile gloves on. Wearing of appropriate surgical attire is important to reduce the risk of post-op infections, right? Because remember, anything we introduce during that surgery has the potential to get in there and grow, right? Um, let's see. This just talks about scrubs, sterile gowns, gloves, all of that stuff. Notice our person has protective eyewear, a mask, head covering. They would have, if they had facial hair, they would have facial covering, all the stuff. And then they are encouraged to wear sturdy footwear, and then you have coverings over your footwear as well. All right, moving on to anesthesia. So term anesthesia is derived from the ancient Greek word aesthesis, saying that totally wrong, I'm sure, meaning lack of or no sensation. Without anesthesia, most surgical procedures performed today would not be possible. The goals of anesthesia are amnesia, analgesia, depression of reflexes, muscle relaxation, and manipulation of physiological systems and functions. These are accomplished through the use of balanced anesthesia, which consists of one to several agents, each with a different action. The agents used depend on the patient, the procedure, and the anesthesia provider's preference. Prior to surgery, each patient is given a pre-op physical exam and evaluation by the anesthesia team. On the basis of that evaluation, the patient is assigned a physical status from the scale developed by American Society of Anesthesiologists providers to assess and assign a perioperative risk, which helps in determining the anesthesia to be administered. This may also be called the ASA status using the same numbering system. So the hospital I worked at, if we had to send people to have procedures done, obviously we just sent them to the OR. But we used to do bedside bronchoscopies all the time. And part of our documentation as a nurse was determining the ASA number on your person. So anytime you are using any type of sedation, you are going to be assigning your person an ASA number. And that just, again, like this talks about, obviously, it helps identify any risk factors that may be present. All right, so there are four major types of anesthesia. We have general, regional, and local anesthetics, and then monitored anesthesia care, or MAC. General anesthesia is what we think of as like being put to sleep, right? So this is a patient under general anesthesia. It's a reversible unconscious state. General anesthesia provides all of the goals stated previously, including manipulation of physiological systems and functions. It is achieved using a variety of methodologies, either alone or together. So this can include inhaled volatile gases, IV agents, and or muscle relaxants. The patient receiving a general anesthetic that includes the administration of a muscle relaxant requires ventilator support in the form of an ET tube. So that means if we use a muscle relaxant, you're going to need help maintaining your airway. So they are going to place an ET tube, you're going to be vented. It's just going to help maintain your airway, okay? So that we don't worry, because if we relax your muscles to the point that they're non-responsive, like you may not have the muscle, you won't have the ability to breathe on your own, okay? So we support that airway. Um, let's see. There we go. All right, so now we're talking about volatile agents and then some of the IV agents, okay? So volatile anesthetic agents, that is just the inhaled gas, okay? So, when we see them put like a mask or something on someone, that's considered a volatile gas, volatile agent. Um, What's interesting, so the potency of the gases is identified as the minimum alveolar concentration needed to achieve the desired effect. So what that means, okay, the lower the concentration, the more potent the gas. So the less of it I need to achieve the desired effect, that means that is a strong gas, right? So all that is saying. So if you are having to identify, two gases, you don't even know what they are, whichever one I need the least of to achieve the desired effect, that is my stronger gas, okay? The book uses the example of sevoflurane, which has a minimum alveolar concentration of 2, whereas nitrous oxide has a minimum alveolar concentration of 105, right? So the sevoflurane, which I am not like familiar with the gases, other than your ones you hear about all the time. But obviously, that one is a way stronger gas with a concentration of 2 compared to nitrous, which has a concentration of 105, right? So kind of interesting. Um, this is kind of cool too. Although these gases have been used for more than 100 years, their exact mechanism of action is not yet clearly understood. Isn't that crazy? So basically, we still don't know how these gases work. Um, some studies indicate that the synaptic transmission of nerve impulses is reversibly inhibited in areas of the central nervous system. So here we are just using these things all the time and we still aren't totally sure what they're doing. Um, so our IV anesthetics, a lot of these you are going to have already talked about in pharm. So they're barbiturates, benzos, opioids, propofol, ketamine, and then you have sedative hypnotics. Okay. Um, barbiturates, CNS depressants, um, let's see, pretty short onset and duration of action. Um, let's see, I'm going through here. Our opioids, I know you're definitely familiar with that. Don't forget that fentanyl is an opioid, right? We hear about fentanyl a lot, but we use it, we hear about it being bad on the streets and killing people and whatnot. But actually, in the hospital situation, we use fentanyl a lot. Okay. Morphine is also an opioid. Okay. And all the things that you learned about previously, like respiratory depression, all of that, keep all of that in mind. Propofol. Propofol is an opioid. We use propofol all the time. Propofol, I don't know if you remember Michael Jackson when he died. The big deal was that his doctor was giving him propofol at night to help him sleep. That's not what you use propofol for. He did consequently die from that. But again, an opioid, respiratory depression is what we worry about. And then ketamine is another one that I feel like we hear a lot about. The thing with ketamine, though, is patients can get kind of crazy hallucinations with it. Um, the book says it's an excellent analgesic and sedative. You know, people have opinions, but that's fine. Um, let's see. We talk about Precedex. I'm sure you guys have talked about that in Farm. There you go. Let's see. The nice thing about Precedex is your person is going to be like semi-arousable, so you can kind of shake them a little bit. But we don't have to worry about respiratory depression, and that kind of sets that apart from other opioids, right? Um, so Precedex was another one we used all the time on people, trying to keep them calm down. All right, here are your muscle relaxants. So muscle relaxants are categorized as depolarizing or non-depolarizing agents. Depolarizing, such as succinylcholine, act by occupying the acetylcholine binding sites at the neuromuscular junction. Um, you really don't have to know that whole mechanism of action at this point. But what you do want to know is that the depolarizing action causes muscle fasciculation. I'm sure I'm saying that wrong. Twitching. It causes twitching, okay, prior to relaxation. So when we use sucks, okay, that's what we fondly call it, sucks, acetylcholine, your person is going to twitch before they really conk out, okay? The onset is about 30 to 40 seconds. You get a really fairly quickly producing paralysis. Okay. I do worry about dysrhythmias related to this. And I worry about malignant hyperthermia, which we're going to talk about. Depolarizing agents cannot be reversed. Okay. These need to wear off. That is, I mean, that can be a problem if your person has an adverse reaction. um Not very likely, but they could, but there's nothing I can do about it. Depolarizing agents just need to wear off. So ventilator support with these are not withdrawn because remember these are our muscle relaxants. So and paralytics. So our person is going to have airway support. We do not withdraw that airway support until we are positive there is no longer any effects related to those depolarizing agents. Okay. Non-depolarizing agents. So here we have some paralytics, vecuronium, rocuronium. We actually used to use rocuronium when we were doing bedside bronchs, and our physicians decided to no longer allow vecuronium. They decided that it was too dangerous as a paralyzing agent, and rocuronium, you pretty much get the same effects, and it's not as risky as vecuronium. So these paralyzing agents, the good thing is there are reversal agents out there. Um, but anytime I paralyze somebody, I obviously worry about them being able to maintain their airway, even if I have given them support. Okay. Um, what's interesting is the reaction to these starts in the smaller muscles, so like the eyelids and the face, and then moves to the larger muscle groups, which includes tongue, neck, and shoulders, and then to the respiratory muscles. Um, this action is longer, it's minutes versus seconds. Um, let's see. There's depending upon what you use, there's differing lengths of onset and duration. Um, but again, your non-depolarizing agents can be reversed. Okay, so that is, I mean, that is nice. Um, let's see. All right, that's pretty much what you need to know. Okay. Um, I would look at this table. There is a table on page 324, table 16.2. It's commonly used anesthetics. We will go over in class which ones I want you to be aware of. But take a look at this. This is definitely something that'll probably come back to haunt you in semester 9. Um, because we don't just use these anesthetics related to surgery. You can use them bedside. You can use them to keep, we had a lot of traumatic brain injury patients, and we would use, propofol, often to just help keep people calm while their brain was healing. So you don't just see these agents related to OR procedures. You do see them out on the floor. This slide just addresses the sequence of general anesthesia. So, one, induction. Obtain IV access, administer sedation, complete when patient becomes apneic. Intubation, so we are going to place and secure an airway. Always remember when your person has an airway, you want to make sure that suction is available. This is applicable to our vent patients on the floor. Um, anybody with an airway, you want to make sure you have suction. Number 3, maintenance. Maintain patient using balanced anesthesia. 4, emergent suction to avoid aspiration. You want to make sure you have your reversal medications, if there are reversal meds available. Um, let's see. And then 5 is recovery. So that means transport to PACU or ICU, and then we monitor that patient until they're stable. Complications of general anesthesia. Obviously, we're worried about respirations, right? Hypoxia, respiratory and CV dysfunction, hypotension, hypertension, right? Could go either way. Fluid and electrolyte imbalances, residual muscle paralysis. Unfortunately, we use these agents sometimes, and especially on our older people, they may not come out of it as well as we would hope. And that's why, remember, we talked about in pre-op, we do all of our baseline assessments, full head to toe and all of that. And part of that is so we can know whether or not they have fully recovered from the anesthetics that we have used. Um, it's not uncommon to have people have residual like neuro effects, maybe dementia, prolonged awakening, or paresthesias. And then, of course, we're talking about malignant hyperthermia again, which we will get back into. Actually, we're going to get back into it right now. Never mind. Here we go. Malignant hyperthermia is considered a medical emergency. So it is a hypermetabolic state that can be caused by exposure to a triggering agent, such as a volatile gas. What's interesting, um, nitrous oxide will not cause malignant hyperthermia. The triggering agent causes sustained muscular contractions related to an increase in intracellular calcium ion concentration. So remember, calcium is calming, right? But remember that it can this is intracellular, so in the cells, not in the serum concentration, okay? So the sustained contractions result in hypermetabolism. So this can cause acidosis, tachycardia, hypercarbia, which is holding on to too much carbon dioxide, glycolysis, which is a problem with sugars now, hypoxemia, and hyperthermia. Okay. Reaction usually begins to occur soon after exposure, but has been known to be delayed until the patient is in the recovery area. So, what that's saying is usually this reaction will take place as soon as we start to administer the volatile gas. The person will have that reaction right away, but they have seen it where the patient has made it through surgery and they're rolled out to PACU, and in PACU they start to have this malignant hyperthermia reaction. So it is important for all of those nurses to be aware of what these signs look like. Um, the most specific sign of MH is skeletal muscle rigidity. However, the book points out that the first sign usually noted by anesthesia or nursing is unexplained tachycardia. Okay. So for the anesthesia provider, hypercarbia is the most sensitive indicator of potential MH. So the body is holding on to carbon dioxide, is what they're going to notice. Um, Let's see. Also, myoglobinuria is another early sign. So the patient's urine turns from dark amber to brown, um, which is kind of interesting. It's related to the red blood cells. A lot of times your person is still going to have a Foley in when they are going to the OR, so you are going to see that constant drainage of urine, right? So in the bag, you're going to notice this change of color. Um, and then hyperthermia, according to our book, is a classic sign of MH, but it's usually a later sign. All right. Um, like I said, this is considered a medical emergency. It is treated with dantrolene. You're going to want to know that. Malignant hyperthermia is treated with dantrolene. It is a muscle relaxant. Okay. Um, we are going to want to cool our patient down. We're going to give dantrolene. We're going to cool our patient. If your person has a lot of blankets on them, whatever, we're taking those off. You can also do stuff like infuse cold normal saline. You could use ice bags around the body, cold nasogastric lavage. Uh, I'm reading through here, seeing what you actually need to know. So malignant hyperthermia, remember when we were talking pre-op, we talked about wanting to know whether or not our person had had any weirdo response to anesthesia before. Well, malignant hyperthermia is one of those things we want to know about. But we also want to know if they've ever had any family members. with problems. And really, you just kind of ask, have you or family members ever had, well, I was going to say adverse, but we probably wouldn't even say adverse. We'd probably just say a bad reaction to anesthesia, because everybody, if they have a story, is going to know that, to share that story at that point. They're probably going to want to share that story. So, malignant hyperthermia is one of those things that we are trying to find out if this is a risk for our person. Okay. Here is your little safety alert from your book about malignant hyperthermia. This is slide 23. We will probably look at this in class as well, but just kind of take a look at that. All right, so regional anesthesia. Moving on to regional anesthesia. This is like our spinal blocks, epidurals, nerve blocks, that sort of thing. It goes into a specific place, spinal canal or intrathecal space. Um, it is going to block pain below the level of insertion, okay? Now, the biggest thing that we worry about afterwards is a spinal leak, right? Um, let's see. So we want to make sure that afterwards our patient's bed is flat. That is going to help avoid a headache. That will also help avoid a leak. Um, let's see here. So we do worry about a rapid decrease in blood pressure related to vasodilation of the sympathetic nerves. Um, So we would be monitoring for that. We would use a vasopressor to kind of counteract that. Spinal headache is a risk with intrathecal anesthesia because of potential leakage of CSF. Usually resolves in 1 to 3 days. We worry about respiratory paralysis if the injection is high up, right? Because wherever we inject, it's going to be below that site that we have paralysis. Um, and then there is always risk of seizure and nerve damage. Okay, so there's a lot of considerations related to regional anesthesia. Risks of regional anesthesia, we just talked about all of that. All right, locals. So locals cause a reversible conduction blockade of nerve impulses when they are placed in proximity to nerve membranes. So a local just goes around the area of whatever we're doing, right? The anesthetic diffuses into the nerves, inhibits the propagation of signals for pain and muscle contractions. Um, Let's see. Just seeing what all you need to know. Some reactions you may have are like hives, itching, rash. Um, and then of course, severe would be anaphylaxis, which obviously is bad. Let's see. Some examples, lidocaine, right? Lidocaine just deadens a small area. Um, I'm sure we're all familiar with lidocaine. Let's see. One of the ones I think is interesting is under esters, cocaine is still used in nasal surgeries because it is such a vasoconstrictor, right? Um, and so they will actually still use cocaine related to certain surgeries. Uh, so there's your fun fact for the day. All right, now we're moving on to MAC, monitored anesthesia care. So this provides anesthesia without unconsciousness. Okay, so the patient has a decreased level of consciousness, but is able to maintain their airway. They can respond appropriately to verbal commands and physical stimulation. We want to maintain consciousness. We are basically elevating their pain threshold whether they like that or not. Uh, It helps with cooperation, right? Some surgeries, you have to make sure that your person is still able to maintain certain functioning, right? So if I'm doing some sort of neurosurgery and I'm like, hey, can you lift your right arm still? You know, I need to be able to make sure that you're able to do that. There is some degree of amnesia, so they are going to have some memory loss related to this. But the kind of the interesting thing is there's minimal variation in vitals. So your vitals should stay pretty close to baseline. And also, this is there's a quick and safe return to activities of daily living. Everything else you're kind of recovering in PACU. There's some side effects that we're monitoring for. Mac really kind of gets rid of all of that. Okay. Let's see. Um, this is super interesting in the book. In particular, they bring this up related to Mac, but all of these, they talk about being mindful of conversations in and around the patient, right? Don't forget that even though our people are sedated, they can still hear, okay? And there have been plenty of stories of people under, full anesthetic, and they have memories of what was said. So, if you are ever in this position or you are working with sedated patients, always be mindful of your conversation and your tone and your comments and, all of those things because just because somebody is sedated does not mean that they're not aware of what we're saying. And even if it's only, I don't know, kind of in the back of their brain, right? We still don't ever want to run the risk of not um, providing a positive environment, I guess. I don't know. All right, airway management. So, if we have to use an ET tube to maintain somebody's airway during a procedure, um, we run risks related to this. Anytime we stick anything in the body, we end up running the risk of causing harm. Okay. The biggest one is laryngospasm. This is where the larynx actually constricts and cannot easily be re-expanded. Um, so that can cause airway compromise, obviously, right? We also worry about patients who have like a small mouth or a short neck or an inability to open the mouth fully. When we did trachs in semester 6, we talked about obese patients. They have a lot more adipose tissue around the neck, and that can be very challenging related to airways. Okay. Also, if your person has facial or cervical injuries, so your motor vehicle accidents, stuff like that. So you have to be aware of all of these things related to airways. Um, because airways can go wrong, unfortunately. Even though we're placing an airway to help maintain somebody's respiratory status, stuff happens. So laryngospasm, that's just kind of a reflexive closure of the vocal folds in response to a trigger. So basically they get annoyed because we've stuck something down there, right? And so they can close up. Um, Let's see. This is why we talk about making sure that you have suction and emergency equipment and everything at the bedside, to make sure that if something goes wrong, then we can do something about it. Another risk that we talk about all the time is aspiration. And also listed on here is tracheal and esophageal perforation. And we talked extensively in semester 6 about the fact that anytime we're putting something into the body, you run the risk of perforating something, right? And that is always obviously a medical emergency. All right, moving on to positioning our people. So, four standard positions commonly used for surgical procedures. They are just kind of modified related to surgeon preference and surgical approaches. And then, of course, the patient's physiological requirements. Like we talked about, some of our bigger people are going to take some some further considerations to reduce their risk of skin breakdown, right? So we have supine, we have prone, we have lateral, and we have lithotomy. And those are pretty much um, our positionings that we use. This slide here, slide 30, goes over supine positions. Supine positions are most frequently used. It's kind of nice because you can get to the anterior surface of the body. So like abdomen, vascular, orthopedic, head, neck, and ophthalmic. Um, so this would be your Trendelenburg. That's where the head is down 35 to 45 degrees. Reverse Trendelenburg, which is head higher than the feet. And then, of course, Fowler's position. Prone position includes face down, head turned to the side. This could be like a jackknife position where the patient is basically in a V. And this is if we have to get to like that gluteal or anorectal area, which is possible. It happens. Then we have lateral, so our person is basically on their side, or lithotomy. This is kind of what we think of related to like OBGYN visits, sort of thing, kind of having a baby, the old way. Nowadays they let you sit however you want to have a baby, but back in the day, it was what was convenient for the physician. All right, this is a safety alert talking about 14 basic safety rules that apply to all patients. Oh, this talks about side rails on your transport bed need to be up, two people to assist on stretcher to the OR table. OR bed and stretcher are locked when patient is being transferred. Yes, please do that. There is nothing worse than transferring a patient and your bed or your gurney starts to roll on you. Spoken from experience. Both side rails of the stretcher are down during transfer. Safety strap is across the thighs once they are on the OR table. Body parts should not extend over the table. Patient's legs should never be crossed. Body parts should not come in contact with metal or any unpadded surfaces. Always consult with the anesthesiologist before touching or moving an anesthetized patient. Move the anesthetized patient slowly and gently. Always check the pressure points and cautery pad if a patient is moved during the procedure. Document baseline skin condition, position, and positioning devices and equipment. Peri-operative personnel should use proper body mechanics when transporting, moving, lifting, or positioning patients. Positioning equipment should be used in a safe manner and according to the manufacturer's written instructions. This is a table on page 332, table 16.5, risks and interventions for surgical positions. Positioning complications. So our older people, right, are always at risk for skin breakdown. Our very thin people are at risk for skin breakdown. Just as we talked about earlier, our obese people are at risk for breakdown. Paralyzed patients, diabetics, anybody who's going into surgery with a pre-existing infection. When we have infections going on, we have a lot of fluid has been shunted to our tissues and whatnot, which make them at greater risk of breakdown. And then anybody who has edema or circulatory issues. So nursing assessments, okay? Again, the OR consents are signed. Remember that that includes a consent for treatment, but it also includes anesthesia and blood transfusions, right? Nursing assessment, correct positioning. We are going to monitor staff related to proper scrub and attire. We're going to validate equipment that equipment is thoroughly cleaned and sterility is maintained. We are going to assess the readiness of the OR suite. We are going to make sure we have the correct equipment and supplies available. And we are going to make sure that our irrigation fluid and instruments are appropriate and available. Our actions, here we go again, the timeout, right? Always with the timeout. And again, remember the order in which these nursing actions are listed in the book are the order in which they want us to do these things. So in order of importance, okay? Timeout, number one. And then equipment safety checks, utilize sterile technique as required, assist anesthesia with intubation, ground the patient, keep patient safety belt in place. That safety belt is a belt on the OR table that goes across the thighs, okay? I've seen where there's 2 belts, before, but the book only mentioned the one that goes across the thighs. So keep the safety belt in place, apply support hose or SCDs, keep the patient warm, accurate count, that's our equipment and um all of our dressings, all of our uh, 2x2s, all of that stuff. Accurate measurement of irrigation fluids. Um, keep OR doors closed during procedure. Keep hallways clear of extra equipment. One of the things with keeping hallways clear is if we have to emergently move someone or evacuate someone for whatever reason, we don't want a lot of things cluttering our halls, right? Patient education. This is going to be related to explaining what the procedure is about, what we're going to do, what the process is going to be, who they can expect to see in the OR, how long things should take, all of that sort of stuff. And then also one of the jobs of the nurse during the procedure is a nurse keeps the family updated. And that's I mean that's very important. So all right, so this concludes chapter 16.